So let's start with the endocrine physiology, the adrenal glands. Okay. The main reference of this is um, sorry. So the main reference of this is your Burn and Levy Physiology, 6th or 7th edition. So these are the lecture outline. Briefly, I will discuss the generalities of adrenal glands. Then I'll go from inside to outside, the adrenal medulla, the adrenal cortex, and then the cortisol and the aldosterone, and integrated response to stress, very relevant nowadays, and some briefly journal articles. So not too much about the anatomy and histology of adrenal glands. So the adrenal glands are retroperitoneal glands just sitting above your kidneys. So the right adrenal gland is a little bit like pyramidal in shape, while the left adrenal gland is crescent shape. So as you know, in your anatomy, these are your blood supply, the right suprarenal gland and the right suprarenal vein for the right adrenal glands, and of course the left suprarenal veins and arteries, or superior suprarenal arteries for the left side. So again, they are just sitting above your kidney, and just telling you that the adrenal gland actually is two organs fused together. So it's the adrenal medulla inside and covered in the outside by your adrenal cortex. So normal weight is about 4 to 6 grams from your anatomy. So again, this is the pyramidal shape, the left side. And the right side, the right side, the pyramidal shape, and the left side, the crescent shape. So cut section shows it says a yellow cut surface. So the fats are yellow, so you can see through here. And so that is the cortex, because the cortex is mainly made up of fat, while the inner medulla is reddish because there is an abundance of blood supply in there. It's a similar slide. So one of the unique blood supply of the adrenal medulla, of the adrenal glands on cross section, is we have the medullary arterioles here and the capsular artery. Take note that they originate from the capsule, I mean from the outside to the capsule and deep into the from the cortex deep into the medulla. Now the purpose of this, because as we can see later, some of the during the activation or the simulation of your epinephrine or catecholamine release, you also requires cortisol for that. So that's why it's important that the blood supply from the cortex percolates deep into the medulla, because that is necessary for it to during the synthesis, and at the same time that is important for the integrated response to stress. So again, this is a cortex, medulla, and the kidney. So cortex, it's important to recognize the cortex because in tumors of your adrenal glands, it will upstage the tumor if it will invade your the capsule. Of course, in the adrenal cortex, you have three zones. So GFR, zona glomerulosa, zona fasciculata, and zona reticularis, and of course the medulla here, or medulla. This is important probably. The adrenal gland is probably one of the most important adrenal endocrine organs. Second, probably from the pituitary gland, because this is like the stereotype or the prototype of your endocrine gland. So we have capsule here, the zona glomerulosa. They are somewhat in cords, or rather, they are somewhat in glands in appearance, while the zona fasciculata, the cells are arranged in cords here, while the zona reticularis, the cells are arranged reminiscent of that of the liver, a bit trabecular in appearance, and the adrenal medulla, we have the hemorrhage here, hemorrhagic areas, because of the abundance of blood supply. So they are dark or deep brown in colors. So if you can remember in your histology, so they are a bit in glandular appearance, and the fasciculata is in cords, and the reticularis here. So take note, in the zona fasciculata, the cells on microscopic examinations are lighter because of the abundance of cholesterol or fats in there. And we have also the medulla here with more blood vessels, prominent blood vessels. So for generalities, the cortisol secretes your steroids hormone, while your medulla secretes the catecholamines. So just take note, your cortisols, aldosterones are seen both in your zona glomerulosa and fasciculata. They just simply varies based on the amount of the steroids hormone. Of the amount of the so there are there are cortisol in your zona glomerulosa as well. While your zona reticularis, there are also percentage of cortisols there, but very, very few. So we're just focused more on the more abundant steroids hormone being secreted by each of the zone. So again, these are just similar slides. Zona fasciculata reticularis. So again, your mineralocorticoids or aldosterone are from your zona glomerulosa. The glucocorticoids are from your zona fasciculata, and the androgens from your zona reticularis. But take note that these are the sex hormone produced by your zona reticularis are just minor, not significant. But that is important also for patient with orchiectomy or removal of your testis. And of course, your medulla secretes your catecholamines, epinephrine, and to some extent, some of the peptides like somatostatin and substance P. So actually, adrenal medulla is a combination of two organs. Your adrenal cortex is actually your endocrine part, while adrenal medulla is more of the nervous or neurocrine, what we term. But because they are taken together as one, we can say that it is now more of it is actually more of a neurocrine or nervous system, but because it's part of a gland, the adrenal medulla, so it is also considered as an endocrine gland. So let's start with the adrenal medulla. So for practical purposes, we can just simply say this is now an endocrine gland. So it's less than 10% of the total adrenal mass. So they're derived from your pheochromoblasts. They are more of nerve actually than your endocrine, especially the chromaffin cells present in there. So from this slides, it's actually part of your ANS, and they act as a peripheral amplifier. And take note, the stimulants or the stimuli are the same with those of your SNS, like exercise, cold, stress, and hemorrhage. And they have direct innervation of sympathetic fibers at T11 to L2. So very much the same with your SNS. That's why it's more of a nervous system than actual endocrine glands. So they secrete epinephrine. So take note here. I just highlighted 80%. Your norepinephrine to some extent are just minor, 19%, dopamine 1. So these three are called catecholamines. So they are produced in response to stress, systemic stress. So take note of this enzyme, the PNMT, the phenylethanol-amine N-metal transferase. This is almost unique to your adrenal glands, because especially to adrenal medulla, and this catalyzes the conversion of norepinephrine to epinephrine. But it is also present to some extent to the brain and organ of Zuckerkand rather. These are your organ of Zuckerkand. These are actually remnants of your adrenal medulla present outside the adrenal glands, usually in the bifurcation of your aorta. So take note of that enzyme. And as I mentioned earlier, the function of this enzyme is potentiated by your glucocorticoids, and thus that signifies, well, the blood supply. Earlier, the medullary artery percolates deep into from cortex to medulla, because you need also glucocorticoids in the synthesis of these catecholamines. Take note that the adrenal catecholamines occurs at the site of production. So Yeah, I will explain further. So the metabolites, so remember the catecholamines are just short-lived. They you can produce that maybe in few minutes or sometimes seconds, but they are also easily metabolized as well. So your epinephrine will becomes your metanephrine. Your epinephrine will becomes your normetanephrine, and together they will become your vanillyl mandelic acids. And these are the enzyme involved here. So epinephrine will become metanephrine, norepinephrine will become normetanephrine. While is vanillyl mandelic acid here is important because this is the measurable substance in your urine, and this is used in laboratory to measure or to detect the presence of pheochromocytoma, which is a cancer of your adrenal medulla. So remember, the adrenal gland is so small, so if you have cancer in there, it may not be detected by your CT scan or ultrasound. Probably it can be detected if it's very large. But remember, the adrenal gland is very small already. So any lesions there may not be seen. But so it's important. But of course, the patient would present with manifestation. And probably the better way to do that is to test for biochemical studies rather than imaging, especially if they are small. So these metabolizing enzymes are present in liver and kidney. So these are the organs where these catecholamines are metabolized to be released by the body. So I mentioned ko na earlier about the pheochromocytoma. That's again the vanillyl mandelic acid, which is the main uh, end product of your catecholamines, formed largely in the liver and to some extent to the kidney. So let's go to the synthesis of your uh, catecholamines. So usually you have already some you have already some norepinephrine reserve in your body. So that is important during fight or flight reactions. Um, so um, but of course, if the fight and flight reaction is still a bit longer, like for instance, you are being chased by an animals, or for example, or we cannot say the pandemic would be a fight or flight reaction because this is more of a chronic type of stress. Because it's so this is like immediate. So the tyrosine is one of your essential enzymes, right? So the tyrosine from these are anything you eat or produce in the body will be convert. The first step in the conversion of catecholamine, of course, is the stimuli. So there should be stresses, colds, hemorrhage, fear. So the tyrosine in your body will be converted into dihydroxyphenylamine through the tyrosine hydroxylase. Take note, I encircle that this is the rate limiting step in the catecholamine biosynthesis. So tyrosine become your X-DOPA. Your X-DOPA will become your dopamine via the amino decarboxylase. Your dopamine will become your norepinephrine via the dopamine beta hydroxylase, now occurring inside the granules. I'll show you later a photo. And then your norepinephrine, which is already present, will be converted into epinephrine, and through a cortisol stimulation, again explaining the presence of blood supply that percolates from your cortex to the medulla, because you also need some cortisol stimulation, preformed cortisol, to convert the norepinephrine into epinephrine by your phenylethanolamine N methyltransferase, which is again unique to your adrenal medulla. Well, almost unique because this is also seen in your brain and organ of sucker candle. And thus you produce epinephrine. So mainly the fight or flight reaction is produced by your epinephrine. Again, the same slides, just encircling the rate limiting steps. Tyrosine hydroxylase. Now this is a better photo. So your X, so there's for instance there is a stimuli. So your L-tyrosine will be converted into L-dopa. L-dopa will be converted into dopamine. The dopamine will be converted into norepinephrine by dopamine by this enzyme, and the norepinephrine will be converted into will be released outside the granules to become norepinephrine, which will be converted into epinephrine by your PNMT. So the tyrosine hydroxylase is the rate limiting steps but the PNMT is the one that will convert your norepinephrine to epinephrine. So it will be released. But although both epinephrine and norepinephrines are involved during their fight or flight reaction, majority is from epinephrine. And if you don't need that, if the fight or flight reaction some epinephrine will be reuptake again into the cells for future research. So take note, although you have already some of the reserved norepinephrine, this entire steps, remember, you have to think that this will be occurring very fast, maybe a minute or maybe less than seconds or minutes, maybe 30 seconds or um, 1 minute or 2 minutes, just to release enough epinephrine for you to have the fight or flight reaction. So how do you, now you cannot have epinephrine and norepinephrine because your action are only short-lived. You cannot have a very elevated type of catecholamines in your blood because the fight or flight reaction is just a short-term response to stress. It is actually harmful in the long run because you can see later everything will be elevated. So it has to stay for maybe 2 to 5 minutes only. You have to convert to other form of response. So your epinephrine will be catabolized again by your COMT. As mentioned earlier, the epinephrine will become metanephrine, the norepinephrine will become normetanephrine. So in the olden times, this is not measurable in your urine or blood. So before, we need the next metabolite, which is the VMA or vanillyl mandelic acid, which is measurable in your urine. And this is necessary again in the diagnosis of pheochromocytoma, which is a cancer of your adrenal glands. Now, as I mentioned earlier, some of your epinephrine and epinephrine are also produced in your CNS. And in the CNS, the final product is not VMA. The VMA is mainly produced in your liver and kidney, but in the CNS, the final product is 3-methoxy-4-hydroxyphenyl glycol. So of course, we do not measure this because you can only measure this using CSF. So maybe you can measure this in research purposes. So this is a composite diagram comparing your um, uh, epinephrine and norepinephrine. So remember, your norepinephrine is also produced in your CNS and in blood vessels, while your epinephrine is from your medulla acting on distant target cells. So just saying that they are more of nervous in functions rather than endocrine. So this is your fight or flight reaction, maybe during exam, fight or flight reaction. But now we have a third. Uh, you may not go into fight or flight. You have this third. We have uncertainty, paralysis, powerlessness, and avoidance. And that is your freeze. So hindi na siya fight. It's just fight, flight, or freeze. So na freeze, uncertainty, paralysis, powerlessness, avoidance. But again, so all of this, maybe this is a more progressive slides, quote unquote. So fight, flight, or freeze. I believe this would still result to the release of high levels of catechol amines. But now in psychology, they said there's the old model is that there's a fight or flight. Then later on there's a freeze. But now the fourth engagement in response to fear is phase. So it's no longer fight or flight or just freeze, but phase. But of course, this is more of a psychology concept. So remember, during your fight or flight reactions, everything is almost always elevated. Bronchial dilatation, exchange of O2, increased cardiac output, inotrophic, chronotrophic, lucitrophic, increased venous return, increased blood flow to skeletal muscles, and you can see here, the only decrease is the blood flow to GI tract because the purpose of that is to direct the blood flow to your muscles. And then also your GI motility is decreased, but the rest is increased. Lipolysis, increased blood glucose, ketone, free fatty acid, lactate, glycerol, glycogenolysis, gluconeogenesis, and everything. So basically, the purpose of this during fight or flight reaction is to maintain your high level of blood glucose, as you know, that is needed to produce ATP and to create all this fight or flight reaction. So, so we have some receptors there. The beta receptors in your target organs. For instance, the epinephrine has a greater effect in norepinephrine, but of course, everything is increased. So take note here, except there's a decrease in glucose utilization. So glucose are not entering your cells. They are kept outside, so they stays in your blood to increase the blood oxygen, the blood glucose level necessary to create this fight or flight reaction. And obviously, the insulin secretion is also decreased because the glucagon will be increased. So again, to maintain your blood glucose in the blood during fight or flight reaction. So everything is basically increased except for this one that I encircled here. So just another slide here. So basically the same, the epinephrine and norepinephrine has the same function, except that epinephrine is more potent than norepinephrine in terms of cardiac stimulation. The epinephrine is also more powerful, about 5 to 10 times. But in terms of construction of blood vessels, the epinephrine is less because norepinephrine is more present in blood vessels. It's not that in blood vessels, it's not that epinephrine is actually less powerful. It is just that epinephrine, the norepinephrine is more available in blood vessels than epinephrine. That's the reason why they have more potent action to increase your arterial pressure. But in general, of course, the epinephrine is more powerful than norepinephrine. So that is for fight or flight reactions. So take note, this fight or flight reactions kicks in less than 30 seconds after the stimuli. So you can imagine those catecholamine will be produced in in those seconds. Of course, as I mentioned earlier, you have some reserve norepinephrine, but it depends on the stimuli. If the fight or flight reaction is so intense, you have to synthesize more. So yun, they are produced. So these are epinephrine and norepinephrine. So I'll go fast. I'll go fast here because it's if I delivered it in a face-to-face pacing, we require 3 hours for this. So this is just really a parallel comparison with your CNS, again, indicating that your adrenal medulla is more of your nervous system organ rather than endocrine. The reason that this is mentioned as endocrine because some of the effects, the reason that this is endocrine because the hormones are concentrated inside your adrenal medulla and they have action away from that organ or a target from the target organ. So it's a hybrid actually between a nervous and endocrine functions, just like here. So this slide is comparing the synthesis of norepinephrine. So if you follow this graph, the synthesis of norepinephrine is pretty much the same, almost with the process occurring in your epinephrine, except that this is happening at the neuromuscular junctions. So tyrosine is still again the precursor protein, become DOPA, become norepinephrine. And the norepinephrine become converted into norepinephrine at the neuromuscular junctions. So as I mentioned earlier, the PNMT is almost unique to the adrenal medulla, but at the same time, to some extent, you can see them in in the brain and in the organ of Zucker-Kandel. So not entirely unique, almost unique. So this slides was discussed to you already in I think in the first shifting topic. So I won't have I won't have, I won't discuss this anymore. So how's the effect of your epinephrine? So they have different effects in your bronchus, liver, skeletal muscles, fatty tissue. But let's take example the liver. Let's take one representative section, since the most important action of your epinephrine is to maintain the blood glucose level during your fight or flight reactions. So let's say you have a stimuli of fear, for instance. So epinephrine will bind to your receptor protein, which is a transmembrane protein across your this is now the cell membrane of your liver. So it will bind here. It cannot cross the inside of the cells because this is hydrophobic. So it can, but it has a binding site here. So the first step is this epinephrine will bind to your receptor protein. This can be an alpha or beta receptor. And at the vicinity of that receptor protein, you have a G protein complex. So in the first step, the binding of your epinephrine with your receptor protein would lead to the dissociation of your G protein subunit into three. So one of that subunit will attach to another enzyme, the adenylyl cyclase, again another transmembrane enzyme. So the combination of your G protein and adenylyl cyclase would results to an activated enzyme. So the binding would activate your ATP to become your cyclic AMP. That's the second step. The cyclic AMP will now activate your protein kinase, which are all again present inside your cytoplasm. And the activated protein kinase will in turn activate your phosphorylase, which is the enzyme necessary to convert your glycogen into glucose. And thus the glucose is released into the blood. So first step, epinephrine binds to receptor protein. The G protein will dissociate here. One of the subunit will bind to your adenylyl cyclase to become an activated adenyl cyclase, which will activate your ATP into cyclic AMP, which is the step 2. The step 3, your cyclic AMP will activate your protein kinase A. And step 4, your protein kinase A will activate your phosphorylase, which will convert your glycogen into glucose. So this process is the same in most other organ, whether it's skeletal muscles or fatty tissue. So the goal is basically to produce glucose that will be available for the blood. So this is the result of your fight or flight reaction. Increased plasma glucose, increased cardiovascular functions, increased metabolic functions, but decreased GI and genitourinary functions. So the purpose of that is for you to be able to run or fight through the stimulus. So this is from your Burns and Levy. So as you can see here, the in-between effect is to produce glucose, maintain the glucose level. To some extent, the adrenal medulla produces adrenomedullin, a peptide product of adrenal medulla, which is still under research. So it can increase your nitric oxide, it can vasodilate, and this is commonly or presently explored as a medicine to decrease your blood pressure. And yeah, that's basically the purpose. It can also decrease your catecholamine release. So a pharmacologic interest, adrenomedullin. So your fight or flight response could be making you weight gain. Why? Because as we can see, all those glucose, you produce a lot of glucose, right? And some of this glucose will be converted, of course, you know, some of this glucose will not be used up during our fight or flight reactions. So yeah, that's one of the reasons. So you know, diba, that some of the people who are always on stress, they become diabetic because of the persistent presence of glucose in the blood instead of those glucose entering your cells. And you have also decreased insulin, as you can see from the previous slides. So that's why. Maybe metabolic syndrome, but ultimately people who are in stress, you can have fight or flight reaction for 5 minutes, but it can also occur several times a day. So you can imagine the stress of that. Now let's go to that. That's the end of your adrenal medulla. Let's go to the adrenal cortex. So the adrenal cortex is divided into three layers or zone: the glomerulosa, GFR, fasciculata, and reticularis. So salt, sugar, sex. Mineralocorticoids to control the salt, glucocorticoids to sugar, and androgen for sex hormone. So na-mention ko na earlier about this. This is your adrenal medulla containing catechol amines. Then the zona reticularis for the sex hormone. And the glucocorticoids, this is the most abundant or the thickest layer. The zona fasciculata containing a lot of, you can see this is a whitish in color, even here also because of a lot of cholesterol or cortisol or fats here. And zona glomerulosa, the aldosterone in the capsule. So again, three layers, sorry. So three layers in GFR, para easy to understand. So the hormones produced are corticosteroids. So overall, we can just mention it as everything produced here are corticosteroids. So this comprise corticoids or the aldosterone, glucocorticoids, cortisol, and sex hormone androgen. So again, remember this, the precursor substance here is cholesterol steroids ring. But this is a cholesterol, cyclopentanoperhydrophenanthrin. So this is the main the precursor substance in the synthesis of hormone produced in your adrenal cortex. While in adrenal medulla, it's the tyrosine. So briefly, I think this is discussed in biochemistry. So any change in the let's say hydroxyl group here, you can change immediately the functions of that hormones. So take note, it is not stored. You do not store the adrenal cortex hormone. It is synthesized as needed. In contrast to adrenal medulla, you have some storage of your norepinephrine because the flight or flight reaction is a very rapid event. So you have already a precursor substance. Para the steps would be just to convert your norepinephrine into epinephrine. But of course, if that is not enough, you have to synthesize more and more catechol amines. So the precursor substance is cholesterol. The adrenal medulla, the precursor is tyrosine. Specifically, it's the LDL, the low density lipoprotein. So take note, the steroids hormone are absent or cellular membrane. So the effect is inside the cell. It's not on the cell membrane. Again, contrast that with the adrenal medulla, where the hormones acts on the receptor present in the cell membrane. Here, the receptors are inside the cells itself. So these are some of the values. So take note here. So it is synthesized as needed. So most likely let's say you are subject to chronic stress or some other stimuli. So you produce more of this corticosteroids hormone. So specifically, the cholesterol is a precursor addition, specifically your LDL, and to some extent your LDL. So your LDL will carry your free cholesterol inside the cytosol of your cells. Now the free cholesterol will be converted into cholesterol esters. So the free cholesterols will be delivered into your inside the mitochondria by your star protein or steroido activating receptor protein, or the star protein. So the free cholesterol from your LDL will go inside the mitochondria. Well, they will be converted into pregnenolone. So the conversion of your free cholesterol into pregnenolone is the rate limiting steps in the synthesis of your steroids hormone. So take note of that. The conversion of your free cholesterol to pregnenolone is the rate limiting steps. The rate limiting steps in the medulla is the conversion of your tyrosine into X-DOPA, right? So take note. And take note, the conversion of your free cholesterol to pregnenolones occurs in the mitochondria. Now we have now a pregnenolone. The pregnenolone will be released back into the cytoplasm, where the actual synthesis will occur. So it is only the conversion of free cholesterol to pregnenolone that is occurring inside the mitochondria, but the synthesis occurs in the cytoplasm. Now, to some extent, if your free cholesterol are not enough, some of your storage fats like the cholesterol esters can contribute, so you produce more free cholesterol. Now take note here that your glucocorticoids is mainly in your zona fasciculata, right? Your mineralocorticoid on zona glomerulosa. But just comparing that both of these steroids have function of one another. So take note, for example, here, your 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 9-alpha fluorocortisol, for example, is mainly mineralocorticoids, about 500 times. The basis here is the cortisol, 1 milligram of cortisol. Well, take note that even if this is mainly a mineralocorticoid, it also has a glucocorticoid functions. So take note here, the aldosterone is mainly a mineralocorticoid, but it also has some glucocorticoid functions. So basically, uh, they share some functions as well. So your glucocorticoid is not mainly for sugar, or your mineralocorticoid is not mainly for salt. They have certain functions depending on the type of your glucocorticoids or mineralocorticoids. So let's start with the outer layer, the zona glomerulosa. This is just an overview again. So it secretes mineralocorticoids produced by, which is actually the aldosterone. So aldosterone is the primary human mineralocorticoids, but there are other also minor mineralocorticoids, which will not discuss today because these are just actually minor. Sorry, it probably be longer, but I'll end at before 12. So okay. So the site of production occurs, we have, take note of this enzyme, important ito, the 17 alpha hydroxylase, the 21 hydroxylase, and 11 beta hydroxylase. So everything that I put as yellow, that's important in the synthesis. And in the zona fasciculata, the cortisol is your main glucocorticoids. Um, Now take note, the glucocorticoids are essential to life and modulate complex physiologic pathways. So why I actually put this essential to life? Take note, the adrenal medulla is actually not essential to life. So the thing is, if you don't have adrenal medulla, you can survive, but you don't have your fight or flight reactions. So probably you are not reacting if you are chased down by animals or have those fear or sudden stress, short-term stress. You will not react, but probably you might die too from the danger of that. But your adrenal medulla is not essential to life. Well, your adrenal cortex is essential to life because glucocorticoids is essential to life. So they have many functions. Also, you already studied this in other endocrine system. So the cortisol feedback mechanism is a classic hormonal negative feedback. So as you know, if you have more hormones, you will start dictating the pituitary gland to stop the production. Okay. Now, the zona reticularis is mainly sex hormone, but these are not significant because your main source of sex hormones are the ovary for females, the ovaries for females, and the testes for male. So I won't touch that very much. So these are the main hormones produced in your zona reticularis, the HCA, the HAS, and androstenedione. Now, so di ba, I mentioned earlier, the conversion of free cholesterol to pregnenolone occurs in your mitochondria, and this is the rate limiting steps in cortisol, in the corticosteroid, in the steroid hormone synthesis. Now, pregnenolone will return to your cytoplasm to start the synthesis of the different kinds of hormones. So actually, they occurs in parallel. We have pregnenolone and 17-hydroxypregnenolone. So we have two. But this happens in parallel. So take note. The main difference basically is the hydroxyl group, but essentially they are the same. They use the same hormone. So your pregnenolone will be converted into progesterone, while your 17-hydroxypregnenolone will be converted into 17-hydroxyprogesterone. Now, the progesterone will be converted into 11-deoxycorticosterone, while your 17-hydroxyprogesterone will be converted into deoxycortisol. And again, by another enzyme, that the 11-deoxycorticosterone will be converted into corticosterone, which is the inert part of your cortisol, while the cortisol itself is the active or the activated form. Okay. So remember, so this is happening, this steps happening in your zona fasciculata, right? While the same pregnenolone in your zona reticularis, it will be converted into 17-hydroxypregnenolone to become your DHEA, and you become your DHAS or androstenedione. So this conversion or this pattern or biosynthesis occurs in your zona reticularis. How about in zona glomerulosa? So again, same precursor, the pregnenolone, become progesterone, become deoxycorticosterone, become corticosterone, become 18-corticosterone, and become aldosterone. So this is happening in your zona glomerulosa. Now, now to put it into all together into a complex or composite happening. So these steps here, entire step here, happening in your zona reticularis. These steps here happening in your zona fasciculata, and these steps here happening in your zona glomerulosa. Now take note, this is important, the hormones that I mentioned. Now we have this so-called newborn screening. So this is part of your newborn screening. So they basically screen about the enzyme, the 21-beta hydroxylase. So take note that if that is deficient, so your synthesis of your aldosterone will be affected, as well as your cortisol, right? But kasi this is are necessary to convert into aldosterone. This is necessary to convert your cortisol. But take note, your the conversion of your sex hormone is not affected. So that's why infant with congenital adrenal hyperplasia are usually have precocious. They have advanced sexual characteristic compared to patient. So those are one of the manifestation of patient with deficiency in your 21 beta hydroxylase, because all of this precursor substance are directed to be converted into androstenedione. So they are not converted into aldosterone or cortisol. So infants are advanced sexual characteristic but have problems with your salt and cortisol and sugar metabolism. Um, if you have problem with 11 beta hydroxylase, um, take note that if you have problem with 11 beta hydroxylase, you cannot have this you cannot develop into cortisol. So you have lacking this cortisol substance. What else? Now, now with regards to aldosterone synthase, that's another enzyme that could be affected. But take note that if you have aldosterone deficiency synthase, you will not have salt wasting problem. Why? So you wonder bakit wala, di ba? Why? Because that is necessary to convert into cortisol. Corticosterone is necessary to convert that into aldosterone. But your aldosterone synthase but patient with aldosterone synthase deficiency will not have salt wasting disease. In fact, they would still manifest with hypertension, because remember, even if you don't have aldosterone synthase or you have deficiency in aldosterone synthase, this enzyme here the 11-deoxycorticosteroid has already some mineralocorticoid activity. So from the table that I've shown earlier, you already have some mineralocorticoid activity. So you won't have a salt wasting problem. So the important enzyme here is 21 beta hydroxylase, 11 beta hydroxylase, aldosterone. Probably, obviously, if you have deficiency in your 17 beta hydroxylase, so you won't have these hormones and these hormones here. But for the most important hormones being studied here in newborn screening, you can also study that in pediatric is the 21 beta hydroxylase, which is also the most common. So problem with 21 beta hydroxylase, probably no hydroxycortisone, and probably some problems with aldosterone productions. But take note, the aldosterone hill will not be produced, but you have no salt wasting problems. But as I will discuss later, that is not just a concern. You really need to have aldosterone synthesis as well. Just saying that salt wasting problem is not part. So the same slides earlier. So I'll summarize again the biosynthesis of your steroids hormone. It's up there. It's the ACTH, which will command your cholesterol to be developed into pregnenolone, progesterone. The OC become your corticosteroid, aldosterone. This is in zona glomerulosa. Now in zona fasciculata, this is the steps. And in zona reticularis, this would be the steps. Okay. So I think this is probably the most important one, if I would say, in this lecture. Yeah. Now these are, again, as I mentioned earlier, they are also, so you also have to metabolize your steroids. If they are not needed anymore, it has to be eliminated in the body. So usually they are done by glucuronide conjugation or sulfate conjugation. So in contrast to adrenal medulla, we have a different ways, and diba? So important to study the biosynthesis and metabolism. And also take note that some of your cortisols are interconverted into cortisone for preserve as well, reserve, and your cortisone can also be converted into cortisol. So sometimes during chronic stress, although cortisol are produced as needed, you also have some degree of reserve as well, which is in the form of cortisone. And these are the hormones that will convert. So your 11 beta hydroxysteroids dehydrogenase 1 is mainly in the liver, while your 11 beta hydroxysteroid dehydrogenase 2 is mainly in your kidney. To interconvert the two. Okay. Let's go to cortisol. Now this is essential for life because it has a lot of long-term effects. There are prevents hypoglycemia, resist long-term stressor to stress, and all of this. Now, as I mentioned, I've already discussed this. So another important effects of your cortisol is the anti-inflammatory effects of cortisol. So the cortisol was tagged before as what we call this is a wonder drug. So before they use it for anything, for TB, for leprosy, anything that tends to be inflammatory, they use cortisol in the olden times. So what are the anti-inflammatory effects of cortisol? So in the immunology, they reduces phagocytic action of your WBC. They reduces fever. They suppresses allergic reactions. So it has a wide therapeutic use. So it is also prone to abuse. Specifically in the immune system, they decrease your eosinophils and lymphocytes, and also the suppression of your T cell and antibody productions. But the importance of this, to balance it out, this is useful in organ transplant. So by slowing down the simulation of your immune system cells, you can also help the patient to reduce the organ rejection, and that is one of the helpful part of your cortisol. But this is now the action of your cortisol again. I probably will not expound more on this, but it is mainly catabolic. So yeah, compared to your, so decreased protein increased protein catabolism, decreased protein synthesis. So everything is catabolic. So increase your blood sugar, suppress the immune system. You can decrease your serotonin, which can cause depression actually. Decrease sensitivity to pain, increase blood pressure. It can heighten your memory and attention briefly. It has a permissive effect on glucagon, meaning when we say permissive, it means it can stimulate your glucagon. It can stimulate or amplify the effect of glucagon, which is elevate your blood glucose and all of this. So take note that there's a prolonged exposure to high cortisol can lead to breakdown of muscles. So you cannot take cortisol extensively. When we say long-term use of cortisol, it's that usually it's 3 weeks, beyond 3 weeks. So it's safe actually to take steroids for infection, for allergy, but beyond 3 weeks you should be careful about that, because the effect like weakening of the bone, immunosuppression will start to appear already. Okay, so now this is again the take note here, maintain muscle function. So this is prolonged use of cortisol. It can decrease your muscle mass. It can modulate your wakefulness. So nagka-insomnia patient taking cortisol cannot appears to be very activated. It can increase your GFR and free water clearance, but it can decrease your bone production by increasing your bone resorption. So it can simulate your osteoclastic activity. It can decrease your connective tissue, inhibit your inflammatory cells, and it can maintain your cardiac output. In a positive side, aside from transplant rejections, I mean, stopping the transplant rejection, this is also important for the maturation of your fetus. So usually, immature babies or premature babies, you can give cortisol because it facilitate the maturation of your lungs in preterm infants. Now, just for this photo, so this is how your cortisol suppresses your immune response. It blocks your interleukin 1, which in turn blocks your interleukin 2 and 6. So these are necessary for your T cell proliferation, B cell proliferation. So in effect, it will block your antibody productions, as well as this in biochemistry. So actually, there are patients, siguro the relevance here is that for patient, if you are going to be vaccinated, for instance, with the COVID-19 vaccine, it is advised not to, if you are taking steroids, you should stop at least that. If that is not, of course, we do not encourage to actually stop that if it is necessary. But if that is just really like maintenance for some controlled allergy, you should stop that. It's said that it can interfere in the antibody productions through this pathway. So you can see it blocks your conversion of phosphatidylcholine to arachidonic acid, which in turn will block your leukotrienes here and everything. So this is a more detailed but I will just mention how the cortisol action. Now, the action of your cortisol is also the same with the aldosterone. So I won't discuss that extensively. So I mentioned earlier, the receptor of your cortisol is not present in your membrane compared to your compared to the receptor of your catechol amines. They are present inside the cytoplasm. So let's say you have a chronic stressors, or the ACTH will simulate the production of your steroids hormone. So some of your glucocorticoids or cortisol will enter your cells, and they can do that because they can be able to cross the cytoplasm. Now, your glucocorticoid receptors, these are very fragile receptors, and they are maintained by your heat shock protein. These are like scaffolding protein to maintain the integrity of your glucocorticoids hormones. So once the glucocorticoids diffuses inside your cells, they will replace your heat shock protein. So this they will replace and actually displace. So now we have your glucocorticoids and glucocorticoid receptors complex, and this complex will diffuse into your or inside their nucleus, and thus doing the effects. They can alter your transcriptions, and that would cause translations, and in turn produce specific genes that would cause this effects in the body, different effects. So step one, your steroids hormone will diffuse through your lipid membranes or membrane lipids. Step two, the binding of the hormone to cytoplasmic or nuclear receptors by displacing your heat shock protein. Step three, the complex will bind to your DNA. Step 4, that binding would result to gene activation. Step 5, transcription and mRNA production. Step 6, translation of protein and essentially alteration of cellular structure or activity. And the cell response, which could be, uh, it depends on the target organs, maybe decrease in bone productions or thinning of the bones, decrease in muscle mass. So it depends. For aldosterone, it's the same. It's the same step. You just replace your glucocorticoids with aldosterone, so they just follow. They also cause dissociation of your chaperone complex or your heat shock protein, and the same. They will follow um, recruitments to translate change in your DNA, mRNA transcriptions and translations. So the cortisol is released followed by your ACTH. So they follow a daily pattern. This is the circadian rhythm. So for the biology major, they already know this, the circadian rhythm. So even the animals, even the fungi, they have this circadian rhythm, meaning they have a day and night patterns. So it follows. So this is controlled by mainly the circadian rhythm is initiated by light. So if the process is occurring mainly in the day, these are initiated by light, but to some extent by sounds and even smell of food. So the cortisol production is a negative feedback. So if you have a lot of cortisol productions, it will send signals to your pituitary glands, uh, to your hypothalamus to stop the productions. So again, what are the stressors or stimulants to produce cortisol? Physical trauma, infection, extreme cold, exercise to the point of exhaustion, and extreme mental anxiety. So take note, these are also the same stimulus during your fight or flight reactions. However, your fight or flight reaction can only last for 5 minutes or less. So after that, the secretion of cortisol will start. So take note, the cortisol production, mainly the glucocorticoids, it is a bit low today. So at this point, noon, di ba, mababa. By 6 p.m., it will be elevated again. And about 8 p.m., it will drop. Uh, it will elevate again around noon, midnight, and very slow in the early morning, but it will spike again about 8 a.m. and noon time. So just to break a little bit, so this is actually this is a flower clock this is in Geneva, in Switzerland. So these are all flowers here. So this are replaced based on so they change the flowers every season. I think this was spring when I took this photo, springtime. So they changed that. So I think this was about 6:30, around 6:30, 7:30 already. But there's still a lot of light at that point. Uh, I think this is already spring to early summer. So we also have this flower clock in Luneta. This is, I think this was actually already in the 70s. So take note again, so the your cortisol follows the rhythm. So take note that this is in sync with your ACTH. It's not the same, but take note, if the ACTH is elevated, after a few hours, your cortisol production is also elevated. So basically, so take note here at 8 p.m. nag-spike, the ACTH spike, maybe 7:30, and then your cortisol spike at around maybe 9 o'clock. So basically, they are in sync with one another. So take note here that this is the negative feedback. So if you have produced a lot of cortisol, the cortisol will send signals to your anterior pituitary, which in turn will signal your hypothalamus to stop the production of cortisol. It's important to have this negative feedback because cortisol, as I mentioned earlier, if excessive, can also be dangerous or detrimental to your body. So the main stimulant or the main features that controls the production is your stress and circadian rhythm. But I would say this is mainly the stimulus is mainly the stress. So same here. So take note of the axis: cortisol, pituitary, hypothalamic, HPA, hypothalamus pituitary axis. So excessive production would send signal to pituitary, which in turn will send signal to hypothalamus. In the same way, the stimulation is from hypothalamus. They produce the cortisol releasing hormone to stimulate your pituitary gland, will produce adrenocorticals releasing hormone that will stimulate your zona fasciculata to produce cortisol. Now take note the in what happened what happened in patient if you take cortisol beyond 3 weeks. You will develop this so-called exogenous corticosteroids or supraphysiological levels. You will have atrophied or zona fasciculata. Atrophied zona fasciculata. So if you take steroids beyond 3 weeks, because you're taking external steroids, exogenous steroids, this axis will not be activated. So in the end, once you withdraw the steroids, because you already suppress this axis, you will suddenly feel the presence of absent corticosteroids hormone, maybe salt wasting, low blood sugar, weakness. So that's why if you take steroids beyond 3 weeks and you need to stop it, you cannot stop it immediately. You have to taper it. So let's say your dosage is 16 milligrams for you have been taking that for 3 weeks. So let's say the doctor says after 3 weeks you want the steroids will only be taking for 3 weeks. You cannot stop that. So by day 22, you will start taking 8 milligram maybe of steroids per day. So after maybe 5 days, you'll start taking 4 milligram and 2 milligram, depending. So you have to taper that slowly to prevent. By tapering your steroids, you will start to activate again your hypothalamic axis, so that your zona fasciculata will start again to produce their own hormones. So you cannot surprise or you cannot stop it. So this is one of the important one. But that is only important if you are taking it beyond 3 weeks. If you take steroids for just 2 weeks, you can actually stop it abruptly, but not for, especially for patient who are taking it for months. You cannot. But that the cutoff so far as I know is 3 weeks. That is considered a prolonged steroids intake already. So this is just the same here. Simple, it's the same with your other endocrine organs. So HPA axis, hypothalamic pituitary adrenal axis. So take note your zona reticularis is not participating in your negative feedback. But that is not, no negative feedback, right? But that is not very important because your zona reticularis is not your main source of your sex hormone. Now, your question is how the ACTH from your pituitary gland actually stimulate your adrenal, your zona fasciculata. So their intermediate action is they can increase your cholesterol esterase. These are the enzyme. yeah, the ester synthase, your star protein. In subsequent level, they can also increase your LDL receptor, your HDL receptor, which is important as a precursor. And in long term, they can also increase the size and complexity of the organelles necessary for the biosynthesis. So they can increase the size of your mitochondria, maybe the complexity of your cytoplasm. So again, so these are immunosuppressant and Cushing syndrome. So in the laboratory, you can test also, you can test the level of your, which part of the axis is problematic. So if the CRH level, so this can be measured in your serum, your CRH, ACTH, and cortisol. If everything is high, the problem is in your hypothalamus. So one of the causes will probably be a hypothalamic tumor or a trauma in that part. So if you have a traumatic trauma on that part or a tumor, it can stimulate your hypothalamus to produce your CRH, which in turn, if you have elevated CRH, mataas din yung ACTH, which in turn will elevate your cholesterol. So it will help the clinician to identify, to pinpoint exactly which part of the axis is problematic. If this is the result, the CRH is low, but the ACTH is high and cortisol is high, the problem is in the anterior pituitary. So probably this is again due to probably hormones, pituitary adenoma or pituitary carcinoma. So yeah. So if the result of your CRH, if the result is low CRH, ACTH is low, but cortisol is high, the problem is probably you have a tumor in the cortisol itself. So you have adrenal cortex adenoma or adrenal cortex carcinoma. So remember, this tumor, they are independent. They also produce hormone, but they do not participate in the axis. So they function independently. They have their own mind. So that's why the CRH level is low, ACTH is low, cortisol level is high. So they actually do not participate. They do not do negative feedback or anything. So yeah, that's a problem. So these are independent. No, sorry. They participate also in the negative feedback pala here. So they participate in the negative feedback here. So CRH and ACTH are low, but they are not controlled by your hypothalamus and pituitary gland to produce. So the main driver of their production is in the tumor itself. But they can produce, they can send negative feedback. So even if they send negative feedback, actually no effect because the tumor is the tumor has mind of their own. So yeah, so they can send feedback, but the CRH level, even if low, will not. So this is the summary of that. So this is an example how the effects of the cortico. This is a Cushing patient with a Cushing syndrome. Maybe this can so this patient might be having so I'll go back for the third one. So the third one, this can be caused by your adrenal cortex adenoma or a carcinoma or abuse of drugs, abuse of cortisol, or prolonged use of cortisol. Not really abuse, but probably prolonged use of cortisol beyond 3 weeks, maybe months or years. So for instance, this patient probably has some kind of, either this patient has an adenoma or probably allergy or whatever, transplant. So you can see the transformation, 2008, 2010. So it started taking cortisol, exogenous cortisol by 2010, or probably there's a tumor. 2010, you can see the progression. 2018, and just after 8 years, the patient is already looking like this. So moon phases, moon-like facies. There's a buffalo hump, so there's a hump in the neck and probably some striation already in the neck area. And you can see the skin, sagging skin. That's how the. So let's go to aldosterone. So this is also this is from the zona glomerulosa. This is again essential for life. This was discussed by Dr. Solidum, I suppose. So they are helpful in your ECF volume productions. the effect is basically in the principal cells, in your renal tubular cells. So these are just generalities here. Maybe I just mention a bit. So essential for life, acute. Again, this is from your adrenal cortex. So essential for life siya. So to some extent, they're also part of the your liquid production in your intestine, or your sodium control in your intestine, colon, and saliva, sweat gland. So take note here, the aldosterone is not just in your renal sodium potassium productions. They're also part of your oxidative stress, in your vascular endothelial dysfunctions. They're also necessary for your cardiac and vascular fibrosis, for hypertension, dyslipidemia, so type 2 diabetes, gluconeogenesis. So take note, your aldosterone should also be managed because they have this effect if they are secreted excessively. So the same function is the same mechanism of functions with that of your glucocorticoids. Your aldosterone binds to your aldosterone receptor, which is present inside the cells. So the binding would bind, the complex would bind to your DNA, resulting to your mRNA synthesis, and then translation to produce your protein, produce a response. So once you have so for here again, aldosterone combines with the cytoplasmic receptor, hormone complex productions. So once of that product, so basically let's focus on here. What are the specific proteins that are involved? So they actually during the protein, after the translations and protein synthesis, the aldosterone actually modulates the existing channels, so more sodium are absorbed, and here, and more potassium are secreted. So they either modulate the existing channels or produce more of these channels as well. So in this photo here, more sodium is reabsorbed, more potassium is released here. So in effect, if you will have increase in urine sodium, increase in urine potassium because and decrease in urine sodium because more sodium are reabsorbed. And in the plasma, you have decrease in plasma potassium and more plasma sodium here. So this is primarily regulated by your angiotensin 2, your RAAS, which was already discussed, I suppose, by Dr. Solidum. And indirectly, so the two important factors here is the angiotensin 2 via RAAS and your potassium level. Take note, the primary stimulus for the release of aldosterone is your angiotensin 2. Okay. And these are your direct stimulator and indirect stimulator of release. So again, these are again your direct effects. So your decreased sodium or increased potassium in the blood can stimulate your adrenal glands, or specifically your zona glomerulosa, to produce more aldosterone. A decreased blood volume or decreased blood pressure by a RAAS, it can stimulate also stress from your hypothalamus. That can also stimulate your ACTH to stimulate your zona glomerulosa. So aldosterone is also part of your response to stress, along with your catechol amines and glucocorticoids. And some of the inhibitory effect is your ANP. So take note here, because of that, you also a bit more of having more edema if you are stressed because of the release of your aldosterone. So, but mainly, if you have hemorrhage, upright posture, and sodium deprivation, that means there would be a decrease in your blood volume, right? Specifically your ECF. And that would be sensed by your JJ cells in your kidney. The JJ cells would lead to the stimulation or the release of your renin. And your renin will convert your angiotensinogen, which is produced by the liver and already present in your plasma, to be converted into angiotensin 1. Your angiotensin 1 will be converted into angiotensin 2 by your angiotensin 2 converting enzyme from the lungs. And your angiotensin 2 would lead to the release of aldosterone, which is actually the main stimulus to release your for the release of aldosterone. And your aldosterone will in turn create all those protein to modulate your channels in the kidney to modulate the positioning of that channel to so that more sodium are reabsorbed, more potassium is released, and also to produce more of those potassium. To some extent, your increased level of potassium would also lead to uh, increase will stimulate your zona glomerulosa to release aldosterone. So the main stimulus actually is your plasma potassium and maybe volume, decrease in volume, blood ECF volume. So in pharmacology, there's an ACE inhibitor, a type of antihypertension, so that they would block the enzyme. So if they block that, you block also the conversion of 1 to 2. So you also block the simulation of aldosterone. So you also block the elevation in your blood pressure. So those are one of the medicine or antihypertensive medicine, blocking this converting enzyme. So take note, if you have low level of blood potassium, that's a negative feedback. So uh, that would result to increase in blood potassium. So increase in blood potassium, as I mentioned earlier, with increase in aldosterone secretions, will also increase in increased potassium secretions, and which in turn will decrease your blood potassium, and the cycle is repeated. I think this is the same slide. So since this was discussed already in the renal, it's the same slide, the same slide. So raas lang din yan. So again, let's summarize the renin-angiotensin system. You have decrease in renal blood flow or decrease in sodium, probably due to hemorrhage, sudden postures, or other causes. Your JJ apparatus of the kidney, which is considered the blood volume receptor, would produce renin. Your renin will convert your angiotensinogen into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by an enzyme produced in the lungs. To some extent, we have also angiotensin 3, but that is not, it's mainly the angiotensin 2. This is the most powerful. The angiotensin 2, it is the main, the most important enzyme or enzyme to produce the production of aldosterone via the conversion of corticosterone to aldosterone. So how actually the question is how angiotensin 2 stimulate the production of corticosterone. What is the exact mechanism? So the angiotensin 2 actually stimulate your aldosterone synthase. So they actually upregulate the production of your aldosterone synthase. So more aldosterone synthase, more enzyme to convert your corticosterone into aldosterone. So that is the mechanism. Okay, so take note here, the angiotensin 2 itself is a vasoconstrictor. So they can actually increase already your blood pressure without the need of aldosterone. Remember, so because they are in itself are constrictor already. So take note here, the angiotensin 2 has different mechanism. How they actually, the angiotensin 2 in this part here, they increase your aldosterone, which in turn will increase your sodium reabsorption, right? But the angiotensin 2 itself can increase your blood pressure because they have direct sympathetic activity here in your blood vessels, in your overall SNS system. Your angiotensin 2 itself can also increase your sodium reabsorption without the need to increase the production of aldosterone. And of course, your angiotensin 2 will have activity in your aldosterone. Your angiotensin 2, remember, is also a powerful arteriolar vasoconstriction, so they can increase your blood pressure in itself. They have also actions in your pituitary gland. So by stimulating your ADH production, it can also increase, so more water will be reabsorbed. It will increase your blood pressure. So the mechanism of angiotensin 2 are 5. 1, 2, 3, 4, 5. So the same slides. So this is again the RAAS system. The RAAS. So just take note in here. So just to discuss to you the relationship blood osmolarity and blood pressure. But just take note. This was discussed extensively naman in the renal part. So let's go to this is the last topic already. So integrated response to stress. So you have mentioned this everything. You have mentioned all of these are the stressors we have pre-pandemic. Now we have the same stressors. So yan. This is the stressors before pandemic. These are now the stressors during pandemic. Okay, so the stressors, so your stressors signals, um, first your first reaction will be your fight or flight reaction. So by the cortex, limbic system, and reticular systems, because norepinephrine's are present in your CNS, that would lead to arousal, behavioral activation, and aggression. And at the same time, during fight or flight reactions, some of your CRH can also stimulate your hypothalamus via the spinal cord, via the medulla, and of course, to release your different hormones, right? Your catecholamines and epinephrine. So that is necessary for energy mobilization and redistribution and cardiovascular responsivity. At the same time, your visceral functions are problematic here. So you develop indigestion, sometimes problems with urine productions or urinary system. And of course, if the stressor is beyond 5 minutes, it becomes chronic or long term, weeks, months, or years. So you produce your cortisol. And as we know, the main function of cortisol is again to energy mobilization, basically to maintain your blood glucose. But at the same time, the prolonged secretion of cortisols can have problem in your immune system. If you are not into if you have no transplant, you have no inflammations itself, it can suppress still your immune system, and that is um, your cytokines, and that's the stress signal. So it's basically everything. So now to expand that, so for short-term stress, the first reaction is fight or flight. So what are the reactions? Mobilization of glucose, changes in circulation, increase in heart rate and respiratory rate, increased energy used by all cells. So for first 5 minutes, but long-term metabolic adjustment may be weeks. So mobilization of remaining energy reserves, conservation of glucose, elevation of blood, conservation of salt and water loss. So ito na yung you are starting to gain weight probably to some extent here. And of course, months or years, there would be a collapse of the vital system, exhaustion of lipid reserve, inability to produce glucocorticoids, failure of electrolyte balance, cumulative structure or functional damage to vital organ. So hopefully we won't go to the exhaustion phase already. So, okay. So take note, the short term is from your catecholamines. The long-term stressors, the long-term response to stress is both from your glucocorticoids and mineralocorticoids. So patients who are stressed are not just having elevated blood sugar, but also elevated blood pressure, immune system suppression, um, high sodium level, and maybe kidney problems. So, so briefly, this is the last one of the last slides. No, so this is just a discussion of your adrenal concept. So your adrenal gland is very central to your different diseases. So depression, because the cortisol can impede your serotonin production. The sepsis, because elevated cortisol can have problems with your inflammatory response. The inflammation, hypertension, because of the excessive production of aldosterone. Cardiovascular disease, you cannot have sustained hypertension, obesity, because of the increase in fatty acids lipolysis, and metabolic syndrome, and osteoporosis, again with increase in your osteoclast activity. Um, so in this study, for example, you can see that take note. Another important one here is that you cannot it is said that in the future we might have a adrenal transplant. So transplant are already done in your kidney, liver, sometimes heart, solid organ. But in this study, it is said that so far, if you undergo transplant, adrenal gland transplant, maybe due to tumor, they do not. It is said that the adrenal glands, a transplanted adrenal gland, does not participate in your HPA axis. So that could be a problem in the future. They have no negative feedback mechanism. So what are your response during the course of critical illness? So very important. So it is said, so right now we have a lot of patient in the ICU. So in this paper, they measure the level of those people who are in the ICU. So when we say critical illness, these are patients who are in the ICU. So it is said that this patient, when they measure the ACTH level, the hormones, the cortisone, it is said to be very elevated. So, um, you wonder why it is elevated. So it is said that that is actually a response in the future, because when you are in ICU, all of your organ systems are actually failing. So in effect, your cortisol and cortisones are elevated. Everything is elevated to sustain your life, to sustain your existence. So elevated glucose, elevated sodium, elevated cortisone. And it is not due to increase in biosynthesis. It is because the catabolism of your cortisol and cortisones are also reduced. So you maintain that level. So, but then of course suddenly, so you wonder, in this study they measured the last few days before the patient died is elevated, and suddenly or the cortisol and cortisone will drop, and that would lead to the demise of the patient. Also in COVID-19, it is said, this is probably one of the least mentioned study. The adrenal cortex is also an underestimated site of SARS-CoV-2 infection. So it's not just the lungs, it's not just the heart. So practically from this paper, we can see that um, the COVID-19 is a multi-organ, really a multi-organ disease, even the adrenal glands. So the conclusion of this paper is they demonstrate that ACE2 and TMPRSS2, these are receptors, are co-localized in adrenocortical cells, and that the cortisol levels are lower in critically ill patients with COVID-19 as compared to those non-COVID-19 critically ill patients. So in comparison, so remember from the earlier journals, it is said that your cortisone and cortisol are elevated in ICU, but that is if the cause is non-COVID. So in this paper, the cause is, but if the cause is COVID, it is said the cortisone or cortisol are already low. So that probably explains why COVID-19 patient who are brought to ICU, of course they assess that at that particular functions have probably very poor outcome or very poor prognosis, because even your cortisol and cortisone, which can help you to sustain your life, to sustain the functions of your body while you are trying to recover, is already low. So this is probably the significance of this finding. So the last topic is, what is adrenal fatigue syndrome? These are now take note, the adrenal fatigue syndrome are not, when you Google in the PubMed, they are not identified, but they are already recognized. This is already recognized by some journal. What are the signs? So this is probably what we call the exhaustion phase: excessive fatigue, non-refreshing sleep, difficulty in concentration, poor digestion, craving for sweet and salty food, low blood pressure, and weight gain. So these are the symptoms. And what are factors affecting the adrenal stress? So we already discussed this. I won't emphasize. So I just add the coronavirus is part, of course, very important part of this stress source. So the four phases of adrenal burnout, probably most people in general are already at this just plain tired, low cortisol, low neurotransmitter. So that's the end of this paper, of this lecture. I hope you, so is it okay na record na ba? So it is that, so that's really the end of the lecture. So I hope you can share the like recording to section A, B, and C as well.
Okay po, Doc.
Na-record ba? Okay naman siguro, di ba?
Yes po, na-record po, Doc.
Okay, so sorry. So that's all. So I think